Vivian all the time that she needs. So I'll start with the intros. Everyone, take your time, grab your food, and take your seats, and we'll get going. Very happy to see a big crowd here today. This is the first edition of What's New in Addiction Medicine for our incoming or now ongoing cohort of medicine fellows. For those of you I haven't met, my name is Paxton Bach. I am the fellowship director for the medicine stream, and very happy to introduce today Dr. Vivian Tsang. Vivian's an addiction medicine fellow and a resident in the psychiatry research track at the University of British Columbia. She obtained her MD from UBC, her MPH from Harvard, and is currently completing her DPhil from Oxford University as a Clarendon Scholar. Most of Dr. Tsang's previous research pertains to the field of addiction psychiatry and concurrent disorders, and she's part of the Addiction and Concurrent Disorder Lab at UBC, conducting research on opioid use disorders and concurrent disorders among patients in BC. She is additionally working with the Road to Recovery group on a project looking at concurrent disorders here, and is the research lead at Roots to Thrive, which is a psychedelic assisted therapy clinic in Nanaimo, BC, and the first clinic to provide psilocybin to patients in BC under special access. So we're very privileged to have Dr. Tsang here today as somebody with quite a substantial amount of clinical experience in a space that I get asked a lot about as an addiction doc, and that's the use of psychedelics and where as a tool, where does the research lie, and where are they going to fall in our toolkit? She's going to give us an overview today on psychedelics in substance use and treatment and in mental health, including some areas that I think are maybe a little bit underappreciated or not discussed often enough. So I'm more than happy to introduce Dr. Tsang. She's going to give her presentation and hopefully have about 10 minutes at the end for some questions. So please hold your questions till then. I'll let Dr. Tsang take it away.
Thanks. Awesome. Hi, everyone. Thanks for coming out to this presentation. It is both an honor and slightly nerve-wracking to be giving the first of the What's New in Addiction Medicine talks for this year. My specific topic for you today is looking at the involvement of psychedelics in addictions and mental health, with the goal of presenting a balanced perspective of the current evidence. I do have a few disclosures. Oop, next slide. Oh, sorry, Raman. Okay, hope I can manage this for the rest of the talk. But currently, as Paxton introduced, a DPhil candidate at Oxford, and my topic of study is in psychedelics. I also previously have been paid by two groups, Roots to Thrive and SHE, which are both private clinics. Roots is a nonprofit clinic, but based here in BC, but no longer funded by any of these groups, and won't be referring to any of the specific therapies there today. So just to start off, so we're on the same page, psychedelics are a class of psychoactive compounds that induce altered states of consciousness. So you can think about perception, mood, cognition, many different domains. And the term encompasses several different groups. There are many different ways to classify them. This is just one of them. Classic psychedelics include things like psilocybin, LSD, DMT, ayahuasca, mescaline, and these are called classic because they are primarily affecting serotonin 2A receptors in the brain. Non-classic psychedelics are things like MDMA, and then there are psychedelic-like agents, so things like ketamine, PCP, that are actually NMDA receptor antagonists, but that are commonly lumped into kind of this group of agents. As of the last decade, there has been a lot of renewed public interest and medical interest in psychedelics, with estimates that hallucinogen use more than doubled between the period of 2015 to 2023, with 8.9% of individuals aged 19 to 30 in the United States reporting past year hallucinogen use, and it's about like 20% lifetime. In Canada, that is a little bit lower at about 6% past year use, but to put that into context, prevalence of cigarette smoking, for example, is about 10%. And I'm sure many of you know much more about that topic than psychedelics. So I think it's quite relevant that we be asking our patients about this and be aware. Unfortunately, a lot of this use is in the recreational setting, regardless of whether individuals use for self-medication or for euphoria, which presents a host of different safety concerns as well. A study regarding patients discussing psychedelic use with their practitioners for therapeutic purposes report that only about a third of them ever really bring it up in consults or in kind of clinical times, which again highlights possible barriers from stigma to legal status in different countries, and then perceived knowledge gaps for physicians. At this point, I think it's also really important to recognize that psychedelics have a deep-rooted history in ritual, medicinal, and spiritual practices of indigenous cultures across the globe, often including things like preparatory fasting, singing, drumming, communal participation, which serve to structure the experience and enhance therapeutic and spiritual outcomes. Archaeological and ethnobotanical evidence also demonstrates that psychoactive plants and fungi have been used in shamanic and drumming ceremonies, many of which continue today. I have listed some examples up here, but by no means exhaustive. Includes the use of ayahuasca in different Amazonian regions, peyote, especially throughout the United States, psilocybin among Mesoamerican cultures, and San Pedro mescaline in Andean cultures. In the early 20th century, there were numerous different discoveries made, which launched psychedelics into the awareness of the Western world. So in 1938, Hoffman synthesized LSD. Many of you probably know the story, where it accidentally spilled onto his hand, and thereby discovering some of the psychoactive effects very much by accident. In 1958, he also isolated psilocybin and psilocin, which then paved the way for chemical kind of characterization of other agents such as ayahuasca. However, despite widespread clinical interest and research into these agents like LSD, psilocybin, mescaline in like the 50s and 60s, the US Controlled Substances Act placed all these agents into Schedule I category in the 1970s and 80s. And then the UN Convention on Psychotropic Substances further then led to global restrictions, which actually resulted in a clampdown of research and clinical development. And since that event in the 1980s, Health Canada has been quite strict on reintroducing psychedelics into the medical landscape for good reasons. But some of the kind of history behind these agents have paved the way for that. So it's a very busy slide. And just as a heads up, I do have like a picture handout that you can like take pictures of, or like actual physical handouts if you want any like slides that include tables and references. I do have that for those who are more academically inclined. So despite growing public interest, psychedelics are not widely available for clinical use, especially in Canada. I've listed here on the slide the number of different pathways that, let's say you have a patient and they're interested in psychedelics. These are the different ways you can access this legally in this country. So starting at the top, clinical trials still remain gold standard for accessing psychedelics legally in Canada. As of 2024, there were approximately 15 psilocybin trials, 2 MDMA, 18 different ketamine trials going on in Canada. Another pathway is an exemption from the law, which was actually how psychedelic access was governed from kind of August 2020 until January of 2022. This later then switched into a program called the Special Access Program. Many of us are familiar with it. We're basically allowing health practitioners to request access to certain psychedelics, specifically psilocybin and MDMA, on behalf of patients with serious or life-threatening conditions where other therapies have failed or are not made any progress. These are long case-by-case approvals, but between the period of 2022 to 2024, about 68% of SAP applications have been approved. So a total of kind of 470 applications, and then 318 were approved in that time period. So people are able to get access in this way. Another very interesting pathway unique to BC began on January 31st, 2023. As many of you know, province received a special exemption 56, allowing possession of small personal amounts of certain drugs, including MDMA. And as many of you know, public possession was then prohibited as of May of 2024. However, with this exemption, patients are still able to access treatment through specialized clinics that then offer like a bring your own medicine type program where they have set and setting of therapy, they have practitioners and nurses and therapeutic kind of interventions, medical interventions available, and then drug testing for medications that folks bring in on their own. There's also a lot of renewed clinical interest amongst all of this excitement, and especially in addictions and mental health. And specifically, I thought that it is thought that psychedelics offer a different approach to treatment of substance use disorders by addressing underlying neural circuits that sustain the addictive behavior component of substance use. So for example, these are just kind of high-level highlights of studies that have been done. So treatment of AUD with psilocybin, LSD, treatment of OUD with ketamine, ibogaine, and other agents, which we'll further go into detail in the next slides. Okay, I won't belabor the slide. I think whenever we see pictures like this, there's a lot of like anxiety around it, but this is really just to show you some examples of mechanistic pathways. So very easily, starting with classic psychedelics such as LSD, DMT, psilocybin, primarily acting through 5-HT2A receptor agonism, and then through a series of different downstream pathways, as you can see up here, leading to synaptic protein synthesis, dendritic spine growth key processes, and underlying psychedelic-induced neuroplasticity. Ketamine acts through NMDAR, which results in disinhibition of glutaminergic transmission and robust activation of the mTOR pathway. This, again, enhances synaptic plasticity. And then another example, ibogaine, primarily targets kappa opioid receptors, initiating intracellular signaling that increases the expression of neurotropic factors. And then other key observations include increased connectivity between the prefrontal cortex and default mode networks, which then is thought to reduce rigidity and increase cognitive flexibility, contributing also to mental health impacts. However, while the exact mechanism of action is still very much being researched for different agents, one very clear finding from the clinical research that has occurred is that psychedelics work best not alone, but rather in tandem with a different sort of therapy. And so the heightened neuroplasticity and connections between the prefrontal cortex and the default mode network really need to be leveraged in order to unlearn rigid thought processes and behavioral patterns, and then relearn new tools and skills, whether that be things like distress tolerance and healthy coping, or to further allow insights and resolutions of past traumas. So the way that I like to kind of really frame psychedelic assisted therapy is it acts as an adjunct. The psychedelic agent is an adjunct to the existing therapy framework, reducing psychological defenses, and making it easier to perhaps access memories or thought patterns that were otherwise avoided in the past. So very busy slide again, handout also available, but there are a handful of different clinical trials and other studies that have really highlighted promising evidence from psychedelics in the treatment of various different substance use disorders. This is a slide for AUD in particular, which has been studied through a number of different, like psilocybin RCTs in particular, one which reports significantly fewer heavy drinking days over a 32-week follow-up period for participants, compared to those who received a placebo. And of note, this was a study looking at psilocybin-assisted therapy, so in conjunction with therapy. There's another study that noted abstinence increased significantly after psilocybin administration, and the intensity of peak effects in the first psilocybin session strongly then predicted change in drinking patterns later in weeks 5 to 8, and then also predicted decreases in cravings and increased abstinence self-efficacy during week 5. This is a slide for tobacco use disorder. Similar research on psilocybin, for example, on smoking cessation, has demonstrated that, again, that single high-dose session combined with CBT can lead to long-term abstinence in a significant proportion of participants. They report a very impressive 80% abstinence rate observed 6 months after treatment. And then OUD, not as readily studied, but a few non-RCT studies demonstrated ibogaine's ability to alleviate withdrawal symptoms and to reduce cravings. There was an observational study with only about 30 participants, but reporting significant reductions in opiate withdrawal symptoms and opiate use, with 50% of participants abstaining from opioids during the first month after treatment and then maintaining improvements, they say, for up to 12 months. A study by Davis et al. Found that approximately 31% of participants remain abstinent from opiates for 2 or more years after receiving ibogaine therapy. However, all of these studies also emphasize the very careful need for monitoring due to different adverse events. For example, with ibogaine having dose-dependent potentials to prolong QTC, which of course leads to serious cardiac events such as torsades, and also drug-induced acute cerebellar toxicity. Now, in both AUD and tobacco use disorder in particular, the significantly positive outcomes that are reported really also reflect optimized protocols. And I think that we need to be really careful and conscious about this when reading the different studies and all the positive results that have been reported. Other than really rigorous patient screening in all of these studies, two items highlighted in the studies were dosage. So for example, higher psilocybin dosages and also accompaniment of structured psychotherapy. All of these results also need to be taken in the context of possible placebo and nocebo effects and blinding in participants, because in almost all of these studies, they do note a high degree of awareness of which assigned groups the participants were in. And if you think about it, of course, it's very difficult to blind someone to psychedelic effects. And some of the control, like placebos that they use, were in some studies a lower dose of the same agent, sometimes stimulants, sometimes other medications like quetiapine or other medications, but it's really hard, again, to simulate that same effect. I have some other key patient factors to consider as well. So baseline psychiatric diagnoses, comorbidities, psychological vulnerability, and treatment variables. So for example, the type of psychedelic agent used, the dose, number of sessions, set and setting, which refer to mindset and presence of structured psychotherapeutic support, respectively. Multiple dosing sessions may also seem to enhance efficacy. And then for sure, inadequate preparation or integration therapy increases likelihood of negative outcomes. Many early studies have indicated that the intensity and quality of a patient's subjective experiences may predict a degree of symptom reduction across conditions. So, for example, studies that used validated measures of mystical experience and emotional breakthrough have indicated correlations with greater improvements in things like depression, for example, following psilocybin administration. However, some more recent studies have indicated that that might not necessarily be the case. And so there is quite a bit of debate still about this topic. But regardless, I think it has been agreed upon that integration is essential for maximizing benefit and minimizing harm. So while the evidence on the use of psychedelics in the treatment of substance use disorders is still quite slim, a lot of the research has actually been on the treatment of mood disorders. And here I actually present some of the larger trials that have come up as of the last couple years. The first two are a comparison of two large head-to-head trials comparing ketamine and ECT. Some of you might be aware of these studies, ELECT-D and KET-ECT. ELECT-D's results show non-inferiority between the two interventions, while KET-ECT demonstrate superiority with ECT. And I won't, again, go too deeply into each of these studies today, but in short, a lot of their results should be taken in the context of patient population again and clinical setting of where the treatments were delivered. So KET-ECT recruitment had a very limited inpatient population and acceptance of way more geriatric patients, for example. However, both trials did induce remission from depression in at least 40% of participants. So for what it's worth, it's interesting comparing those two studies and considering why they had different outcomes. The last study on the right-hand side there, ESCAPE-TRD, compared S-ketamine nasal spray with XR quetiapine on the background of SSRI-SNRI for patients with TRD, and also reported positive outcomes. On that note, I wanted to mention that S-ketamine is really the only Health Canada approved ketamine product for mental health treatments. And it is pretty important to note that there are a lot of market forces incentivizing study of esketamine, which is currently still under patent over racemic mixtures, which has been widely used in anesthesia and emergency medicine as a generic medication for many, many, many years. And as a quick refresher, I've included a little diagram there for those of you who might not be familiar with esketamine. Ketamine is what we call a racemic mixture. So it has two mirror image compounds. One is esketamine and one is R-ketamine. It has historically been thought that esketamine is more beneficial because of the increased NMDA antagonism. However, recent studies have also noted that R-ketamine seems to have unique benefits and acts through a number of other receptors. So more research needed as well, but this is just for context to understand what this product S-ketamine is. So both products can have a role in treatment of things like depression and suicidality. And the existing evidence doesn't really provide much guidance on situations that would favor like one over the other. And some studies that have been done comparing the two have actually favored the racemic ketamine over S-ketamine. There have also been a number of trials and studies looking at psilocybin for major depressive disorder, especially in patients who have been refractory to treatment. So many of you probably know about the landmark Carhart-Harris study in 2021, which was a phase 2 RCT involving patients with long-standing moderate to severe MDD. And the study compared psilocybin with escitalopram over a 6-week period. Results across that period show that there's no significant difference across the two groups when they used assessment of change on a 16-item kids SR depression scale for that. There's also the COMPASS trial, which was run by Goodwin et al. In 2022. And this was a population of adults with treatment-resistant depression, randomly assigned to receive a single dose of their synthetic formulation of psilocybin at doses of 25 milligrams, 10 milligrams, and 1 milligram, which the 1 milligram was used as a control, along with psychological support. So they did have some kind of therapy there. And their primary results in analysis revealed psilocybin at a single dose of 25 milligrams, but not the 10 milligrams, reduced depression scores significantly more than the 1 milligram dose. But their period of study was over a period of 3 weeks. But again, the large studies that are more common here. And while we're talking about all of these recent trials and all the evidence in the last few years, psychedelics are also associated with a number of different risks. And I think this is the part that I really wanted to talk about because I don't think it really gets highlighted in presentations or information about psychedelic-assisted therapy. So in general, I would say that safety data indicate that at therapeutic doses, psychedelic-assisted therapy is generally well tolerated in controlled settings. And there are really common adverse events across the different agents. So like transient headache, nausea, anxiety, mild perceptual disturbances makes sense. Particularly at high doses, experiences might be actually frightening and may include paranoia, a loss of boundaries, distorted sense of self, impaired judgment, and lack of supervision might also lead to risk-taking behavior, of course, which then indirectly can link to things like traumatic injuries or even death. In certain cases, re-traumatization can happen, especially at high doses of psychedelics, and especially when they're used without concurrent or preceding therapy. And then combining substances, for example, using psilocybin-containing mushrooms with things like cannabis or amphetamines or alcohol in conjunction elevates the risk, of course, even more. On the rarer occasion, HPPD, or hallucinogen persisting perception disorder, is a mental health disorder where a non-intoxicated individual re-experiences the same perceptual disturbances or the same types of disturbances that were experienced while they were intoxicated on the agent. The prevalence is estimated to be approximately 4% among people who use hallucinogens, and interestingly, highest rates among folks who use LSD. And symptoms might include kind of any kind of perceptual perturbations, but visual disturbances tend to be really common. And a key part of the diagnosis is that patients are still aware that the disturbance is caused potentially by the substance. So they still have intact reality testing as well. So individuals predisposed to or who already have an existing psychiatric condition, especially a previous history of psychosis, is also at elevated, of course, risk of side effects, including things like flashbacks, persistent psychotic states, depression, suicidal ideation, and continued problematic use. There was a large mixed method study with 608 participants, and it was found that the risk factors for prolonged difficulties include lack of knowledge about the dose or drug type, unguided settings, prior psychological vulnerability, and adverse acute experiences. A very interesting study that was published, I think, last fall by some researchers at the University of Ottawa tracked 9.2 million people aged 14 to 65 in Ontario between the period of 2008 to 2021. What they tracked were ED visits involving hallucinogen use in kind of any capacity. And any types of hallucinogens, so including things, dissociatives like ketamine in this cohort as well. They compared this to a general population without these types of ED visits, as well as to subgroups, one of which is alcohol-related presentations to ED, and the second one, cannabis-related ED visits as control. And actually quite shocking results, but their results report a 21-fold higher risk of developing schizophrenia spectrum disorders within 3 years, with a crude risk of 4% for the hallucinogen ED group compared to 0.15% in like the normal population group. Even after adjusting for kind of co-occurring comorbidities like mental health diagnoses, they still report a 3.5-fold increased risk, with 4.7 times risk compared to those with alcohol-related visits and 1.5 times higher compared to those with cannabis-related visits. And then in general, they also noted that the ED visits involving hallucinogens rose 85% between 2013 to 2021. And while for me reading this, like the results are really shocking, it also reflects limitations of the study, right? Because it is a cohort study that didn't have the ability to kind of distinguish between patients who potentially may have developed schizophrenia spectrum disorders regardless of their substance use. The study is also not representative of patients who have used hallucinogens and psychedelics, but who never present to the emergency and have never had some kind of crisis related to their substance use. And then they also further didn't distinguish between the reasons why people used hallucinogens. So we don't know if those people who presented because they were self-medicating already. Maybe they had already had some psychotic symptoms but never sought care for it, whether they were using for therapeutic use versus those who may be just using for recreational purposes or for achievement of euphoria. So, but this is pretty interesting and hopefully the first of many studies to come that actually track these outcomes. Now, this is not an exhaustive list of where kind of caution might be warranted, but there's some considerations and some agreements between both the American and the Canadian psychiatric associations on patients or groups who might be should be excluded from psychedelic assisted therapy. So first of all, including people with personal or family history of any psychotic disorders. And there are some kind of emerging clinical trials on looking at other indications for psychedelic assisted therapy, but this in general has been the recommendation so far. Most existing groups also exclude patients with diagnosed personality disorders, especially borderline or other severe personality disorders. And that's because it is thought that they might experience worsened dysregulation when in unstructured setting. And it's really important to practice caution when considering treating these folks in this type of therapy. This also includes individuals with prior prolonged or adverse reactions to psychedelics, so including things like HPPD and other items that we mentioned earlier, persistent depersonalization or derealization, folks who have poor insight to begin with and where maybe there's no ability to provide structured therapy or kind of adjunctive therapy. And of course, folks who, they're not able to provide informed consent, or those in unstable or unsafe psychosocial environments probably should not undergo psychedelic therapy and for sure should practice caution when referring. So in terms of specific adverse events across controlled clinical trials, both ketamine and psilocybin have demonstrated therapeutic potential for mood disorders, but neither are really risk-free, right? Some common acute effects are usually, again, transient and manageable, but there are distinct short-term physiological and psychological risks, and some rare but pretty important longer-term considerations as well. So I know this graph is very small, so I'll try and read some of it out. But this represents data from a 2019 NIH paper assessing side effects associated with a single sub-anesthetic dose of intravenous ketamine infusions. 188 participants were pooled from 4 different placebo-controlled crossover ketamine trials and 1 open-label study. And in all, they reported that the most common side effects were, of course, feeling strange and weird, spacey, woozy, loopy, dissociation, floating, visual distortions, difficulty speaking, and numbness. And these patients were folks with either treatment-resistant major depressive disorder or bipolar disorder, and then 25 healthy controls. In particular for ketamine side effects, also important to note things like dissociation, nausea, vomiting, cardiovascular events are also really important as well. We do know that ketamine increases blood pressure and heart rate with about a 13 millimeter of mercury kind of raise in BP, which actually creates issues with participants who have any kind of unstable cardiac disease or uncontrolled hypertension. So many of these groups that provide ketamine-assisted therapy do baseline vitals on day of treatment and actually send patients home in the event that their blood pressure is not able to be controlled on kind of repeated measurements. In addition to the more common acute adverse events, effects of ketamine, there are also a small number of rare but also pretty clinically important events to think about. These that I've listed here primarily have come from like case reports and long-term kind of safety extensions of S-ketamine and IV ketamine trials, but again, kind of sparser documentation. There's one very well-documented case report of ketamine-induced cystitis in a patient receiving repeated therapeutic infusions for treatment-resistant depression. Isolated urinary events like retention and incontinence have also been observed, but generally are mild and reversible. And this highlights that I think many of us know about the dramatic kind of bladder toxicity that's seen more commonly in recreational settings. It's rare in therapeutic contexts, but vigilance is definitely still important, especially with the repeated dosing, which we don't know very much about, and we're starting to do more research on is kind of the maintenance components of this kind of therapy. For hepatic effects, there are roughly 6 published case reports of liver injuries associated with therapeutic dose ketamine, usually after, again, repeated or prolonged exposure. These cases do describe elevations in ALT and AST, sometimes with cholestatic patterns, but these all resolved with the discontinuation of the therapy. And there are also at least 7 published case reports of mania or hypomania emerging after sub-anesthetic ketamine administration, and then 1 to 2 cases noting paradoxical worsening of things like depression and suicidality during S-ketamine maintenance treatment. There also has been case reports on acute transient psychotic episodes associated with intranasal S-ketamine. So all that to paint, not that many numbers of different cases, but still very important to consider, even in the event of, prescription of S-ketamine, which is the Health Canada approved product. The acute adverse events of psilocybin in controlled clinical settings are largely psychological in nature and tend to occur during or shortly after the dosing session. So across modern clinical trials in depression, anxiety, and substance use disorders, the most commonly reported effects are transient anxiety, fear, or psychological discomfort, which actually is quite high. So occurs in about 20 to 30% of participants. Again, the experiences are usually short-lived and well-managed through therapeutic interventions and support, and actually in some cases might be considered part of the therapeutic process. Physiologically, we see, again, this transient rise in systolic blood pressures and headaches, which is high. So 20 to 30% of participants across different pooled studies. Nausea and dizziness, as well as transient perceptual disturbances, of course, are common and generally well managed. Now, in terms of rare adverse events, again, looking at case reports, there are at least 5 different published case reports describing persistent psychotic symptoms or prolonged perceptual disturbances after psilocybin exposure. Different case reports of manic episodes, and again, paradoxical worsening of psychiatric symptoms after treatment. Very rarely are there cases of physiological complications, though again, this has been described in some papers as well. So again, highlighting that there is a lot of further research needed in this field. These are just some of the areas where hopefully research in the coming years will answer a lot of our questions in terms of prescribing practices, which patients to refer, for example. So the first piece that I wanted to highlight is more research needed on maintenance after the initial course of treatment. So right now, we don't really know what maintenance really looks like. So should we be prescribing lower doses? Should we be prescribing like our normal psychiatric medication, psychotherapy, some kind of combination? How much maintenance is required and what does that look like? There have been some studies looking at this question in particular, but what is really lacking is the long-term follow-up in the existing and the different RCTs that I'd mentioned. Many of them only follow for the course of weeks, sometimes months, but not much that are much longer than that. Second piece is studies to date on the association between psychedelic use and other treatment disorders, for example, have been scant. So even in terms of the treatment of substance use disorders, even though I presented quite a couple of slides on the different trials that have been going on, limitations include kind of really small sample sizes. Sometimes, again, the placebo and nocebo and unblinding effects really kind of weaken the general applicability of those trials and those results. So we don't really know kind of how durable these benefits are. Another gap is the lack of head-to-head comparisons. So we don't know which patients benefit more from, ketamine versus psilocybin versus MDMA. There are some ideas, but really there's no comparison between the different agents. And then how these treatments compare with other established therapies for different indications. Safety data, even though, again, I presented some rare side effects, some common side effects, all of this is kind of compilated from these different isolated case reports, right? There are no large scale registries. No one's really kind of keeping track of all of these papers and studies together. And then most trials are also conducted in really highly controlled research settings with very intensive psychological supports, really, really rigorous patient recruitment. And so we don't yet know how well these results will translate into real world community practice. And filling these gaps will require longer, larger, more diverse studies, standardized outcome measures, and then systematic post-marketing surveillance. So just some considerations to think about, and of course, many other areas of research other than what I'd mentioned, but hopefully this gives kind of an inkling of ideas of what's to come and starts kind of all of you thinking about any questions that you might be asking your patients, how you might be screening for substance use disorders and screening for kind of concurrent use of psychedelics among other agents. Anyway, I'll pause there and then take any questions. I think I actually left a good amount of time because I'm sure that there's some thoughts in the room and happy to try my best to answer that.
Well, thanks, Vivian. That was an outstanding, I think, review of the current evidence and what does seem like a new frontier, but I appreciate kind of your tempering some of the excitement. Well, everyone's collecting their thoughts. I'll ask a question and then we'll open up to the audience. I'm really curious about a comment you made early on in your presentation around the benefits being seen primarily when psychedelic therapy is being used in conjunction with psychotherapy or talk therapy. I'm wondering if that's something that's being demonstrated empirically or if that's more of a perception from people who've been involved in either the research or the clinical practice. And I'm particularly interested if that applies as much to the treatment of substance use disorders as much as mental health diagnoses, considering how we have seen psychedelics being used in our space, often in Mexico or other international settings where I don't think that that's necessarily happening.
Mm-hmm. Yeah, great question. So certainly there are anecdotal reports on both ends, right? Like there are people who have gotten better with no adjunctive therapy and they go to Mexico or the Amazon or somewhere in the world and they get a single dose of ayahuasca or mescaline or whatever it is, and then they come back and they're better. There are, of course, studies that show the other outcomes, and what from looking at literature and looking at reports of cases, I think more of the evidence points to the need for adjunctive. I mean, I would consider it like adjunctive psychedelics to therapy. rather than the other way around. But like, yeah, so adjunctive therapy to psychedelics or vice versa is really where the evidence stands. And even from an anecdotal and clinical perspective, we can think about, those of us who either have done operations where ketamine is used, or if you work in the emergency and you give patients a dose of ketamine for, relocating their shoulder or something like that. Very rarely do people say, hey, actually, that event that happened where I got the high dose ketamine, like I'm suddenly better, my depression is much better. That hasn't really come up. And so, you have to think about that piece as well, in taking all of this kind of evidence into context. Another consideration is there have been now a number of different private clinics that have opened up with single dose psychedelic, especially in the United States, and many of them have not continued in their business. And so we have to think about why that is, and why if the clinical impacts of the psychedelic agent in isolation is so strong, then why has there not be a maintenance, even from a commercial standpoint, of this kind of therapy? So yeah, I think all of that points to the need for adjunctive therapy or adjunctive psychedelic to ongoing therapy. But there have been some literature, especially with the S-ketamine trials. For those of you who are familiar with the different kind of protocols there, they don't have that rigorous of therapy, from my perspective and psychiatric perspective. However, their results have been maintained somewhat. And there are lots of thoughts about those studies, which I won't go into. However, that for what it's worth, evidence on both sides, but those are my thoughts. Great question.
Okay, I'm gonna see if anyone, I don't know if we have anyone listening online. Do you know is there anyone online?
Yeah, there's a couple people online. Yeah.
And if we can see.
Just me chatting. I think
Okay.
Gypsy just shared some resources.
We have. Oh, I'll share at the end. Okay, so nope, if there's questions online, if there's anyone online, you can please type your questions in or let us know and I hopefully can unmute you. Any questions from the audience? Start with Jeff Tran.
One of the I have a specific question. One of the things you mentioned for average effects was hypertension. Is that of the psychedelics? I've heard from some of my colleagues issue this specific, I guess, I think specifically static hypertension. Wonder if that's something that you read about that came across your practice at all?
Yeah, a lot of that, I would say, like, for sure, 100%, that's been described in literature and also encountered clinically. A lot of that could be mitigated by how, again, the setting is set up. So I won't comment on this too much, but from an anecdotal and clinical perspective, we've now transitioned to having patients lie flat for a prolonged period of time, and then really addressing the nausea component of side effects. And that has seemed to reduce the instances of like seemingly orthostatic hypotension by quite a bit. But 100%, that's been seen, like both described in literature and encountered clinically. Yeah. Sorry. The question was whether we've seen instances of hypotension and in particular orthostatic hypotension described in literature and clinically. Yeah.
Yeah, thanks. That was great review. And I always appreciate including the historical context as well. Just in terms of understanding some of the resistance or reluctance with Health Canada, I wonder if in your history, you didn't mention in psychiatry, we have with McGill, Dr. Cameron, a particular history with experimentation with psychedelics. I mean, is that part of the reluctance? I wonder if you feel that that's overshadowed some of the subsequent developments. And it is still in the news actually over the summer. I remember seeing there was a class action lawsuit that some of these patients are.
Yeah. Yeah, no, it's a good consideration. I think in general, the psychedelic landscape has had a lot of unfortunate instances, not just that isolated event, but even in the States, there have been issues with like MAPS USA, for example, with different types of lawsuits and considerations from patients and situations where even in a therapeutic context and in a well-intentioned context, patients have been very much harmed. And I think that all of course, needs to be taken into perspective. And I think it is good for Health Canada to be vigilant in terms of how they're allowing access to therapy and actually making sure that the patients that are being treated are treated in facilities that have, all the right medical, infrastructural metrics and supports. That being said, there are, I didn't mention it today, but there was a ruling last summer by the FDA on kind of MDMA breakthrough status and the situation around that. And there's a lot of contention around actually what happens in these meetings and who was represented and different groups aside from like clinical and medical groups that are involved in this discussion. So everything, I'll just be more general here, like from pharma to lobbyist groups, to advocacy groups, groups that don't think that psychedelic medicines should be a medicine in like the traditional kind of Western worldview of medicines, right? As I mentioned in this presentation, these agents have been used for millennia by Indigenous and other cultural groups. And so, of course, like all of that, it's a very complicated situation. And yeah, I think all of that plays a role in the Health Canada kind of decisions and in access. But yeah, thanks for your question. Did that answer it a little bit? Okay, thanks. Any other questions? Yeah, hey.
Curious whether for the substance studies, like the nicotine cessation, whether there's any sort of like standardization to like a therapy session before, like what's the mindset of the patient when they go in and just have a psychedelic experience, or are they having any sort of like they have to go in thinking I'm going to stop using cigarettes after this?
Yeah, a lot of the studies, and as I mentioned, like the evidence is most robust for studies that include a preparatory, so like a pre psychedelic session and in integration, so a post psychedelic session therapy program. And a lot of these studies, they use either like a traditional known therapies like motivational interviewing techniques or CBT are most common, but they do describe a significant amount of robust therapy, and especially in like some of the earlier studies by groups out like John Hopkins and out in Imperial in the UK. So yeah, patients are prepped in terms of like their goals of the session and what their motivations are and kind of where they see their lives after this. And so there's a good degree of communication and thought and attempt to foster insight even before the psychedelic session. And we do see that the evidence supports this approach. There is no standardization or protocol, which I think is missing in terms of course, the studies, but also like it begs the question of should there be a standardization or approach, or is it warranted for the approach to be flexible depending again on the agent, the dose, the type of patient, the indication? That is to be determined, but I think there's considerations on both sides. Yeah. That.
Thanks, Vivian. That was a really great presentation and really interesting. I'm just wondering, because I mean, this talk is about addiction too, is the addictive potential of hallucinogens themselves. We know typically not so much, but particularly ketamine, if there was any precautions in these particular studies in terms of people who are maintenance ketamine, or if that's going to be evaluated. Sure.
Yeah, no, definitely. And originally I had a very short version of this talk for AMCT teaching and included a lot more of the clinical kind of components and screening in there. So I appreciate the question. And just to repeat for anyone who's online, the question was around addictive potential of psychedelics and in particular ketamine. All of the studies, all of the more rigorous studies, so like the RCTs and different trials, the screening for patient recruitment is really stringent. So anyone who may potentially have had like a previous issue with kind of substance, like a psychedelic use disorder, were considered, and that was mentioned in a lot of the screening. And in terms of the maintenance component, all of the groups that have talked about maintenance have some type of medical follow-up. So either they're like meeting with their psychiatrist or with a family doctor like regularly during that period, or before their top-up dose or a maintenance dose, they'll have another consult or like an abbreviated consult. I have to be honest, I don't know the particulars of the questions that they asked or whether they really elicited information about, whether somebody is accessing these agents outside of this trial or in another way. But I think that's really important. And I think over time, as we learn more, especially around ketamine and maintenance, more of that will need to be standardized in terms of protocol and making sure that patients are adherent to treatment and making sure that patients are adherent to follow-up as well, beyond the psychedelic component of treatment. Yeah, great question. Any other questions?
I have one more.
Okay.
So I'm curious, I'm just reflecting. So given the pretty profound difference in mechanisms between some of these agents, I'm curious if you see, like in 10 years or 20 years, will you see us having talks on NMDA antagonists and serotonergic agents, or do you think there's like something about the shared experience that will continue to be classified or discussed kind of together as a whole?
Yeah. Oh, that's a good question. I don't know. I think clinically, anecdotally, and looking at the literature, they act differently. Like these agents are different agents. And even though right now they share and they're classified as like a group because they share a lot of common kind of like clinical symptoms and manifestations, I think they fundamentally work differently. And when we know more about like what kinds of indications they're best for, which patients respond best to different kind of, whether it's ketamine or psilocybin, and whether they have depression or if they have, PTSD, I think we'll begin to have more kind of narrow focus on each one as their own agent. At least that's my hope, that we learn more and have more science and have more evidence to be able to have those discussions, not as like a whole kind of, potpourri of psychedelics, but each on its own, and to know more about how they can help our patients. Yeah.
Hey, any other questions? Last call. If not, oh, one more. Okay.
Thank you so much for a great discussion. I was wondering for counseling patients, particularly with microdosing psilocybin for mood symptoms,
Yeah.
what sort of recommendation?
Yeah, I actually had a microdosing slide, but I decided not to share it because that would be very granular. But I would say there's different. I mean, microdosing is not like a treatment that we would prescribe. So it's more so like the patient is microdosing, and we want to just, we want to support them and make sure that at least they're being honest with us. There are studies on microdosing regimens, and so there are like structured. You take these different agents on day 1, 2, 3, and you kind of repeat over the course of however long you're microdosing. And there are some strategies in terms of kind of like known ways to microdose. So I would say like from a safety standpoint, that would be the best that we have right now in terms of giving patients resources. But I think from like a clinical perspective, I don't think we're in a position where we're going to be like, okay, like this is your microdose. At least for the time being, and important to let patients know, depending on why they're coming to see you or why they're, disclosing that they're microdosing, that they're still treated for their primary indication, whether that is depression, that they are still, first line agents are still there, right? We're not referring people to psychedelics as a first line treatment. So I think important to kind of explore those pieces first. But otherwise, like all that kind of being said, there are existing regimens with some scant evidence, either as kind of cohort studies or observational studies available. Yeah.
Okay. So with that, thank you all for attending today, and thanks, Vivian, for just a really outstanding start to the year for what's new.
Thank you.
We will see everyone again next month, I hope. Okay.
Thanks.
Thanks.